Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. David Miller from the University of Texas Southwestern Medical Center in Dallas, Texas, and Dr. Angeles Alvarez Secord from the Duke Cancer Institute in Durham, North Carolina. They will be discussing key data for ovarian, endometrial, and cervical cancers presented at the 2022 SGO annual meeting held in Phoenix, Arizona. This episode is part of a larger educational program entitled 2022 Global Conference Coverage, an update on the clinical development across gynecologic malignancies. For more information on Dr. Miller and Dr. Secord, along with a link to the complete program, including a downloadable slide set and clinical commentaries, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about key results presented at the 2022 SGO annual meeting.
Welcome. I'm David Miller, Chief of Gynecologic Oncology and Professor of Obstetrics and Gynecology at the University of Texas Southwestern Medical Center in Dallas, Texas. It is my great privilege today to be joined by Dr. Angeles Alvarez, who is a professor of obstetrics and gynecology in the Division of Gynecologic Oncology at the Duke Cancer Institute of the Duke University Health System in Durham, North Carolina. Welcome, Dr. Secord.
Thank you so much, Dr. Miller. It's a pleasure to be here with you today.
Today, we will be highlighting some of the key studies that were presented at the 2022 Society of Gynecologic Oncology annual meeting that was held in Phoenix, Arizona. And we'll be focusing on key data for ovarian, endometrial, and cervical cancer. So first, I will start off with some ovarian studies, and then Dr. Secord will talk to us about some updates in endometrial and cervix cancer, and we'll chat a little bit about some questions and comments. So turning first to those ovarian studies, our first trial to discuss is the efficacy and safety of niraparib as maintenance treatment in patients with newly diagnosed advanced ovarian cancer using an individualized starting dose, the PRIME study. This was presented as a late-breaking abstract by Dr. Ning Li of the National Cancer Center of China. In the PRIMA study, niraparib demonstrated statistically significant improvement in progression-free survival regardless of biomarker status. In this study, the PRIME study was conducted to evaluate the efficacy and safety of niraparib using an individualized starting dose as a maintenance treatment in Chinese patients. In this double-blind, placebo-controlled, multicenter phase 3 study, patients with newly diagnosed advanced ovarian cancer with a complete or partial response to first-line chemotherapy were randomized 2-to-1 to niraparib or placebo. A starting dose of 200 milligrams once daily was used, except in patients with baseline body weight of 77 kilograms or a platelet count of greater than 150,000. Those patients received 300 milligrams a day. The primary endpoint was progression-free survival. The secondary endpoint included overall survival. Of the 384 randomized patients, 33% were germline BRCA mutated. 67% had homologous repair deficiencies. Median progression-free survival was significantly longer among patients who received niraparib compared with placebo at 25 versus 8 months with a hazard ratio of 0.45. All subgroup analyses demonstrated consistent treatment benefit. Among patients with germline BRCA mutations, the median progression-free survival was not reached in patients receiving niraparib and was 11 months in the placebo arm with a hazard ratio of 0.4. Patients without germline BRCA mutations, the median progression-free survival was 19 months with niraparib and 8 months with placebo with a hazard ratio of 0.84. In patients with HRD, median progression-free survival was 25 months with niraparib and 11 months with placebo with a hazard ratio of 0.58. In patients that were without HRD, who were homologous repair proficient, the median progression-free survival was 14 months with niraparib and 5 months with placebo, with a significant hazard ratio at 0.41. While overall survival data are not yet mature, there was a trend in favor of niraparib at the data cutoff. Grade 3-4 treatment-related adverse events were observed in 49% versus 7% in the niraparib and placebo groups, respectively. The most common grade 3 or worse adverse event in the niraparib arm were anemia at 18%, neutropenia at 17%, and thrombocytopenia at 14%. Adverse events leading to dose reduction of niraparib occurred in 40% of patients in the PRIME trial, compared with 71% of patients in the PRIMA trial. Similarly, the discontinuation rate was less due to adverse events and was 7% in the PRIME trial versus 12% in the PRIMA trial. The authors concluded that the PRIME study confirmed the efficacy and safety of niraparib as a single agent in Chinese patients. Patients who received niraparib had a clinically meaningful and statistically significant improvement in progression-free survival, regardless of biomarker status. So our next trial is the final overall survival results from SOLO3, a phase 3 trial assessing olaparib monotherapy versus nonplatinum chemotherapy in heavily pretreated patients with germline BRCA1 and or BRCA2 mutated platinum-sensitive relapsed ovarian cancer. This was presented by Dr. Richard Penson from the Massachusetts General Hospital. As previously reported by Dr. Penson in JCO, in the SOLO3 trial, olaparib provided significant improvements in objective response rate and progression-free survival compared with single-agent non-platinum chemotherapy in patients with germline BRCA mutated platinum-sensitive relapsed ovarian cancer who had received greater than 2 lines of platinum-based chemotherapy. Here they report the final overall survival and second disease progression results from SOLO3. Patients were randomized 2-to-1 to olaparib 300 milligrams BID or single-agent non-platinum chemotherapy. Primary endpoint of the trial was objective response rate by blinded independent central review using RECIST criteria. Secondary endpoints included overall survival, progression-free survival, second progression-free survival, time to first subsequent treatment, time to second subsequent treatment, and time to treatment discontinuation or death. 266 patients were randomized. 14% of the chemotherapy patients withdrew before receiving study treatment. Prior analysis of SOLO3 showed olaparib generated an overall response rate per BICR of 72% versus 51% with chemotherapy. The median progression-free survival per BICR in the olaparib group was 13 months compared with 9 months in the chemotherapy group, reducing the risk of progression or death by 38%. In this report, 11% of the olaparib patients versus no chemotherapy patients were still receiving study treatment. Overall survival was now similar with olaparib and chemotherapy, with a median overall survival of 35 months for olaparib and 33 months for chemotherapy with a hazard ratio of 1.07. Following disease progression, most patients received subsequent anti-cancer therapy, 60% for the olaparib patients, 61% for the chemotherapy patients. 26% of those chemotherapy patients received a PARP inhibitor as their first subsequent line of therapy, with a total of 38% of patients receiving a PARP inhibitor at some subsequent time in their treatment. At the final disease cutoff, PFS2 favored olaparib over chemotherapy at 24 versus 20 months. The median time to first subsequent therapy was 15 months in the olaparib arm versus 11 months in the chemotherapy arm with a hazard ratio of 0.49. Additionally, the median time to second treatment with olaparib was 25 months versus 20 months in the chemotherapy arm with a hazard ratio of 0.75. The median time to discontinuation of death was 13 months in the olaparib group versus 5 months in the chemotherapy group with a hazard ratio of 0.2. Adverse events were consistent with previous SOLO3 analysis and no new safety signals were identified. Discontinuation of study treatment because of adverse events occurred in 10% of the patients on olaparib and 20% of the patients on chemotherapy. MDS or AML developed in 3% of the olaparib patients versus 4% for the chemotherapy patients. Circulating tumor DNA analyses were done. Notably, 6 patients presented with BRCA2 reversion mutations at baseline. Among these patients, no responses to olaparib were observed. The authors concluded that in the primary analysis of SOLO3, olaparib improved overall survival and progression-free survival compared with chemotherapy. However, in the final analysis, PSF2 favored olaparib monotherapy over chemotherapy, but overall survival was similar in both treatment arms. The authors did suggest this supported the use of olaparib as a chemotherapy-free treatment option in this patient population. And our third ovarian trial is the efficacy and safety of mirvetuximab, soravtansine in patients with platinum-resistant ovarian cancer with high folate receptor alpha expression. The results from the SORAYA study, and these were presented as a late-breaking abstract by Dr. Ursula Matulonis from the Dana-Farber Cancer Institute. As we know, available single-agent chemotherapies for platinum-resistant ovarian cancer have limited activity. Mirvetuximab soravtansine, that we will call MIRV, is an antibody-drug conjugate comprising folate receptor alpha antibody, a cleavage linker, and maytansinoid DM4, a potent tubular-targeting agent. Findings from a prior pooled analysis showed that MIRV elicited an overall response rate of 31%, a median duration of response of 8 months, and a median progression-free survival of 4 months in patients with folate receptor high, platinum-resistant ovarian cancer who previously had received 1 to 2 prior therapies, including bevacizumab. SORAYA is a global single-arm phase 3 study evaluating MIRV in these patients. SORAYA enrolled patients with high levels of folate receptor alpha expression by immunohistochemistry. Patients received MIRV at 6 milligrams per kilogram every 3 weeks. The primary endpoint was objective response rate. The key secondary endpoint was duration of response. 106 patients were enrolled. 48% had 1 to 2 prior lines of therapy. 51% had 3 prior lines. All patients received prior BEV. 48% received prior PARP inhibitor. The median follow-up time was 8.5 months at data cutoff. Objective responses by investigator was 32%, including 5 complete responses. This was confirmed by BICR. 15 responders remaining on MIRV at the time of data cutoff. In patients with 1 to 2 priors, the overall response rate was 35%, and in patients with 3 priors, it was 30%. Patients with prior PARP inhibitor, the overall response rate was 38%, and in those without prior PARP, it was 27%. The most common treatment-related adverse event included blurred vision, keratopathy, and nausea. Treatment-related adverse events led to dose reductions in 19%, dose delays in 32%, and discontinuations in 7% of patients. Only one patient discontinued treatment due to an ocular event. The authors concluded that in platinum-resistant ovarian cancer, folate receptor alpha expression predicts benefit from MIRV. MIRV demonstrates durable anti-tumor activity with favorable tolerability regardless of number of prior therapies or prior PARP inhibitor. And they thus stated that MIRV represents an important advance for this biomarker-selected population.
Thank you so much, David, for sharing these studies that were presented at the recent SGO meeting. I have some questions for you. I found the data very provocative, and especially I just want to start from the beginning with the PRIME trial and then move down the list. With the PRIME trial, we really have several robust randomized clinical trials in this arena now evaluating PARP inhibitors as a frontline maintenance in patients with advanced ovarian cancer. How is the data from the PRIME trial differ from the other studies that have been presented so far?
Well, I think most important is that it differs from the PRIMA study in that it included all patients and not just the suboptimal debulk patients, for which I'm sure at the time they were hoping to have more events. So this, this was more of an all-comers study. It confirms in a larger trial their dose modification schema, even though they went about it a little bit differently, probably because they have more smaller patients than we have. And importantly, and again, we see that in patients who are homologous repair proficient, there was an advantage for giving the PARP inhibitor niraparib. And it certainly is a little bit more compelling data or addition for us to contemplate giving a PARP inhibitor to all of our patients who have responded to platinum-based chemotherapy.
Right, that kind of fits into the second part of this question, and you just mentioned it in terms of the suggestion of what you should do. So now I'm going to ask you, has this study changed your treatment recommendations for your patients? Are you in fact recommending a PARP inhibitor for all patients in the frontline because of this trial, or were you doing that anyway?
I frequently have to remind my fellows that even in the PRIMA study, there was an advantage for the HR proficient patient. I think that should be part of a discussion with the patient. In the PRIME trial, if you look at those hazard ratios, they were all pretty much the same, very similar across the groups. I know they probably weren't designed to be compared. I think this is something that we need to discuss with patients, and certainly this suggests more of an advantage than we had seen, say, with PRIMA.
And that's a perfect segue into the next study, which is SOLO3. So great trial, very provocative results, but I think this is an issue of timing, really, because as you mentioned, we have several trials in the frontline setting supporting the use of PARP inhibitors in various patient populations, and then the PRIME trial supporting its use in the frontline setting. So given the use of uptake for frontline PARP inhibitor maintenance in this patient population, especially in our country, can you comment on the relevancy of the SOLO3 data?
Well, that's sort of the goal of all of our clinical trials, is to make them irrelevant over time, and this was a step along that path. However, we still see patients who haven't had a PARP inhibitor yet, and we would expect about half those time by some tests they will be HRD, and this is more compelling evidence that if they haven't had a PARP inhibitor, they ought to get a PARP inhibitor. Now, we still need to answer the question about PARP after PARP. Does that same PARP, a different PARP? We don't know the answer to that yet.
So one of the issues I thought was quite curious, and it goes into that sequencing question, which you just mentioned about where do you hit PARPs in here, PARP after PARP or PARP after chemo, chemo followed by PARP. is the MDS AML frequencies. And I think it's hard to make too much of this because the numbers are so small, but the frequency is slightly higher in the chemotherapy arm. And one of the things I would really like to know if these patients have received a subsequent therapy with a PARP inhibitor and that increased their risk of MDS and AML. And again, these numbers are incredibly small. Do you think that this may inform anything about sequencing?
40% of the chemo patients eventually got a PARP inhibitor. So it's kind of not surprising that maybe their MDS AML was a little bit higher, because obviously we tend to blame the last thing that the patient got. However, likely it has to do with the sum totality of all their prior treatments. But again, this is sort of another little nudge to move us into using PARP inhibitors earlier as opposed to later.
All right, wonderful. Thank you for sharing your thoughts there. So with this next question, I'm certainly forecasting my own thoughts here and emotion. Wondered, how excited are you about mirvetuximab?
We have a targeted therapy that appears to work on the target. At least every meeting we go to, we have some so-called targeted therapy that didn't work on the target, or it worked on things that weren't the target. This is fitting nicely into our paradigm. The study authors have been working hard to identify the best population, the criteria for folate receptor alpha positivity seems to be a little bit more stringent than some of the prior studies. And so this is another thing that I would anticipate moving up into frontline therapy in patients who have the appropriate target.
I share your enthusiasm. Often it's so hard to treat any patient who has recurrent gynecologic malignancy, but certainly patients who have platinum-resistant ovarian cancer, it can be really heartbreaking sometimes. And this response rate is much higher than we would see with many standard of care therapies. So I'm hopeful that we can move this forward in the clinic and be able to offer this as an option for our patients. So one of the things I really wanted to discuss with you is, assuming FDA approved mirvetuximab for this indication, do you foresee any barriers to access for this agent for our patients?
Well, you touch on the problem that we have here, particularly, we work at a large county hospital, Parkland, and so having to call in other consultants to try and treat your patients, particularly ophthalmologists, to help us manage eye toxicity is very much a challenge because, everybody's busy and these aren't particularly entertaining or lucrative exams for our ophthalmology colleagues. If you make a gynecologic analogy, how would we feel having to examine a patient for a pelvic exam for a patient who got a chemotherapy that happened to give them a vaginal discharge? Patients wouldn't be like that very much, and we probably wouldn't like it very much. I'm hoping that as we learn more about these various ocular toxicities, that we'll be able to take care of it and make these treatments a little less labor intensive. We've gotten up to speed on immune toxicities, and now we have ocular toxicities to step up our level of expertise.
Yeah, I appreciate your comments there. Those are certainly things that we've thought about. The other one I just want to mention to you is, this treatment will require a companion diagnostic. And how do you implement that in your clinic? When do you send that testing off? Should we send it off when the patient's initially diagnosed or at the time of diagnosis of platinum-sensitive recurrence? And what will the turnaround time be for the testing?
I think as I understand it, and that may not be a good understanding, hopefully this will be something that our pathologists can do. They might have to buy a kit, and that we don't know what the expense of that will be. But hopefully it is something that can be done locally as opposed to centrally.
Well, times are certainly shifting for ovarian cancer. So Sherry, thank you so much for sharing all those abstracts. And I would like to highlight this study, which is a randomized phase 3 trial of maintenance selinexor versus placebo after platinum-based chemotherapy in patients with advanced or recurrent endometrial cancer. This was a late-breaking abstract presented by Dr. Ignace Bergoat from the Catholic University in Leuven in Belgium. And this study was very interesting. It's a maintenance strategy, essentially. And I wanted to also say this wasn't just the Siendo style, it was the GOG 55 trial. So 3055 trial. So some of our sites, GOG sites also participate in this study. And patients had stage 4 or first relapse endometrial cancer, and they included several different histologic subtypes: endometrioid, serous, undifferentiated, or carcinosarcoma. Patients had been previously treated with chemotherapy and had either a partial response or complete response on at least 12 weeks of first-line treatment. Prior surgery, radiotherapy, or hormonal therapy was allowed. In total, 263 patients participated in this study, and they were randomized 2-to-1 in favor of selinexor. And they were dosed with selinexor 80 milligrams q weeks. I want to take some time and talk about the mechanism of action of selinexor. This is a first-in-class agent, and it's so exciting to see all these new first-in-class drugs. Selinexor is a selective inhibitor of nuclear export, and this drug selectively inhibits XPO1. And this essentially prevents or helps tumor suppressor proteins not migrate out of the nucleus. So it reactivates and amplifies tumor suppressor proteins. And the tumor suppressor protein that comes to mind most notably for the GYN patient population is the p53 protein. And this is a tumor suppressor protein. And when it is reactivated by this drug and amplified, it induces tumor cell apoptosis. And I want to really highlight that because this mechanism of action will be very important as we start to review some of the efficacy findings. The patients in the study were stratified based on primary stage 4 or recurrent disease, as well as whether they had a PR or CR. The primary endpoint was progression-free survival by investigator assessment, and there were multiple secondary endpoints, including overall survival, PFS by BICR, patient-reported outcomes, and other additional endpoints of survival outcomes and PFS too. There were several predefined exploratory endpoints based on histologic subtype, and very importantly, molecular subclassification, including p53, mismatch repair, protein expression, and POL mutations. And let's next look at the demographics. And what I want to point out here is the randomization, for the most part, did work. The median age was similar in both groups, approximately 65 years of age. Most patients had an excellent performance status of 0. And the most common histologic subtype was endometrioid, approximately 55%, with about 30% of patients having serous cancer, followed by a small representation of undifferentiated carcinosarcoma and other endometrial adenocarcinomas in this histologic subtype. In terms of the prior number of anti-neoplastic regimens, over 95% had just one prior regimen. And the most patients had recurrent disease, 55% in the exploratory arm and 51.7% in the control arm. About 40% of patients had a complete response in the selinexor arm and approximately 45% in the placebo arm. The investigator assessed the median progression-free survival was 5.7 months with selinexor and 3.8 months with the placebo, which translated to a hazard ratio of 0.705 and a one-sided p-value of 0.024. The hazard ratio did not cross 1, so selinexor did demonstrate superior progression-free survival compared to the placebo control arm, and the reduction in disease progression was approximately 30%. But the magnitude of benefit, if you just look at the median PFS cut point, was actually very small, only 1.9 months. And you can see that the tail end of these curves, they do flatten out and they do not come together completely. But I do want to spend some time on this because this just shows that this study is statistically significant findings, but the magnitude of benefit calls into the question the clinical significance. But let's move on to the next set of survival curves. And these are stratified based on histologic subtype. So endometrioid on the selinexor arm with a median PFS of 9.2 months versus placebo with a median PFS of 3.8 months. The hazard ratio here is 0.573 with a p-value of 0.014. So we do see that perhaps the endometrioid histologic subtype, there is a benefit with the experimental drug, and that translated to a 6-month median PFS difference, but an over 40% reduction in disease progression. And from a biologic point of view, this makes sense because endometrioid cancers are more likely to have an intact p53 gene and p53 protein. We see the opposite story in serous cancers. Patients who had serous cancers and treated with selinexor had a median PFS of 3.8 months compared to 3.7 months with placebo. These survival curves completely overlap. And you wouldn't necessarily expect a benefit from this agent because serous cancers are more likely to have a mutated p53 gene and aberrant protein expression. Let's move on to the next survival curve, which to me was actually the most striking. But again, I do think we have to take into account that this was exploratory data and certainly a hypothesis generated, but needs to be confirmed. And we see the greatest benefit in patients who had wild-type p53 with selinexor, having a median PFS of 13.7 months versus 3.7 months. The hazard ratio here is 0.375 with a p-value of 0.0003. So we have, essentially 60 plus percent reduction in disease progression. We have very wide survival curves here. And this is very exciting data. And from a biologic point of view, it makes sense that perhaps this drug that targets wild-type p53 keeps it in the nucleus and reactivates it and causes tumor cell apoptosis, that this makes sense. I want to move next to the adverse effects of this agent and focus on grade 3 and 4 treatment emergent adverse events. And you can see for the most part, this drug is very well tolerated. Of the grade 3 and 4 side effects, nausea is the most predominant one, followed by thrombocytopenia, fatigue, asthenia, and neutropenia. And when you talk about any grade, we do see that patients do have a high frequency of nausea here. So this is certainly something we need to learn how to mitigate better. As you mentioned earlier, David, as we get more comfortable with various drugs over time, we're able to mitigate some of the side effects proactively. And so I'm hopeful we would be able to do the same with this agent. Selinexor did require dose reductions about 50% of the time and dose interruptions, but patients discontinued drug only 10.5% of the time. So about 11% of patients discontinued the agent. And in terms of quality of life, patient-reported outcomes, there was no significant difference between treatment arms in global health, physical functioning, or symptoms, including diarrhea and nausea and vomiting. So essentially, this phase 3 SIENDO GOG 3055 trial of selinexor versus placebo maintenance in patients with endometrial cancer demonstrated significant anti-tumor activity with a PFS of 5.7 versus 3.8 months and a hazard ratio of 0.75. But I do think that when we take into consideration the patient subgroups, when we're evaluating all patient subgroups, I don't really think that this is potentially a clinically meaningful difference, but there does appear to be a signal that's of significance in patients with endometrioid histology and p53 wild-type tumors. The finding of not seeing this difference in serous cancers, I don't think is surprising based on the mechanism of action of this drug. And the fact that the quality of life data was similar for both treatment arms is reassuring. The treatment emergent adverse event profile demonstrated that this drug had manageable side effects. And hopefully with supportive care and dose modifications, we can mitigate the nausea-related issues. So the next thing I'm going to talk about is completely different. We're going to talk about cost effectiveness now in cervical cancer. And so this study is taking data from the Keynote 826 trial, which, as you and our audience is very well, was a truly exciting trial that demonstrated that pembrolizumab, when added to chemotherapy with or without bevacizumab in patients with persistent, recurrent, or metastatic cervical cancer, had improvement in progression-free survival and overall survival with a strong clinical benefit and really changed the standard of care. So all of my patients who have either persistent, recurrent, or metastatic cervical cancer, I am discussing this regimen with them, and patients are opting for treatment with a pembrolizumab and platinum-based chemotherapy with a discussion about the inclusion of Bev. But as we know, all of these drugs do add cost, and there was some concern about adding 4 drugs now rather than 3, and how to identify who's going to benefit from these drugs. We know the trial had some interesting results, but the FDA approval was for patients who had PD-L1 positivity and not for all comers. This study was presented by Dr. Barrington from the Ohio State University. And it evaluated the previously standard of care chemotherapy with or without Bev, and the overall survival ranging from 12.9 to 17.0 months. This was a study that was initially presented by Dr. Tewari and was published in 2014 in the New England Journal of Medicine. And they compared it to the study from Keynote 826 that was published by Dr. Colombo in the New England Journal of Medicine as well. And the addition of pembrolizumab to chemotherapy with or without Bev yielded a median OS of 24 months and resulted in the FDA approval, as we mentioned. The primary objective of the study presented was to determine the cost effectiveness of chemotherapy and pembrolizumab with or without Bev versus chemotherapy and bevacizumab. They evaluated the total cost of treatment, the effectiveness as they deemed by the quality adjusted life years or QALYs, and then the incremental cost effectiveness ratio, also known as ICER, which is essentially, ICER is the difference in cost divided by the difference in effectiveness defined by the QALYs. So let's go on and see what some of their assumptions were. And this is information regarding their model inputs for cost. And so essentially here, there's 3 different regimens they evaluated: chemotherapy plus bevacizumab, chemotherapy plus pembrolizumab, and then the third one, chemotherapy plus pembrolizumab plus bevacizumab. The assumptions were for a median of 6 cycles of chemotherapy and a median of 11 cycles of bevacizumab in the chemotherapy plus Bev arm, and 13 cycles in the chemotherapy plus pembro plus Bev. And the median number of cycles listed there are 9 for chemotherapy and pembro, and chemotherapy and pembro plus Bev at 13. So that's median cycles of pembrolizumab. And the median overall survival was 16.5 months for the chemotherapy plus Bev versus 24.4 months for the 2 other arms. And they determined the cost for the various therapies, cisplatin, paclitaxel, bevacizumab, and pembrolizumab. And they also modeled inputs for adverse events. So this is just one example here for their model for grade 3 and 4 anemia. And they modeled the probability of anemia for the chemotherapy and Bev arm at 0.26 and for the other arms at 0.3. And they also determined health state utilities, which was 0.75 for patients with recurrent or metastatic cervical cancer compared to 1 for those in perfect health. And the next step here is evaluating the QALYs for each of the different regimens. And the referent here was chemotherapy plus bevacizumab. And the ICER, or the incremental cost effectiveness ratio, so basically chemotherapy plus pembrolizumab had an ICER of 92,678 compared to the referent, which was chemotherapy plus Bev. And chemotherapy plus pembrolizumab plus bevacizumab had an ICER of 361,000 compared to the referent of chemotherapy plus Bev. And that was dominated. The willingness to pay threshold, which is WTP, and that's 100,000. And they did a 2-way sensitivity comparing the efficacy of the bevacizumab containing regimens. And the chemotherapy plus Bev and pembro's chemotherapy and pembrolizumab and chemotherapy and Bev. And their 2-way sensitivity analysis demonstrated that chemotherapy plus pembrolizumab appears to be more cost effective compared to chemotherapy plus bevacizumab. And the comparable relative contribution for pembrolizumab versus Bev was observed. However, I think it's very important to note that the data is insufficient to justify omission of bevacizumab, and that this model may underestimate QALYs if a appreciable number of patients are cured with treatment, and we don't have that data yet. Maybe at some point we will with updated analyses in the future, but at this point we don't. And the cost and reduction of pembrolizumab would render chemotherapy plus pembrolizumab and Bev cost effectiveness. But I'll tell you, David, that is always the case with these cost effectiveness studies. Addition of these drugs is rarely cost effective, taking into consideration the high cost of these agents.
Thank you for your very keen analysis. That doesn't leave too much on the table, so I'll have to ask you to do some little speculation. So with selinexor, we have this new agent with a new mechanism of action. However, the FDA also looked at the study with a very critical eye and thought the evidence was not quite there for registration. And supposedly discussions are underway for a confirmatory trial. You have any idea what that might look like?
I have an idea what I'd like it to look like, but I do want to say, if I could just comment on this for a second, we see our patients with endometrial cancer every week. It seems like there's more and more patients. And we recognize that despite all the improvements we've made for treatments and surgeries and radiation, that there's more patients dying from this disease ever before. And really that Black women are at the highest risk of death. So I almost feel there's this huge sense of urgency that we have to find something and we need to do better now, because it's just becomes such a crisis, if you will. And so when this data was presented, I was just so excited to see something being done in endometrial cancer beyond immunotherapy. Don't get me wrong, I'm totally excited about immunotherapy as well, but to have a novel class of drugs being evaluated was really exciting. Yeah. But in terms of the question that you asked me, I say I agree, because number one, when we look at this data on a figure, and you're looking at these survival curves, I've always felt this way, that hazard ratios don't exist in a vacuum, and that we really need to look at all the data in totality, not just focusing on a median time point of progression-free survival, but that median progression-free survival in context with the hazard ratio and in context with evaluating, landmark data. What does the data look like at 18 months or 24 months, and what's going on with the tail of the curves? And when you look at the all-patient, all-comers, and you take into consideration the mechanism of action of this drug, it doesn't make sense that it's going to work in all patients, especially those patients who have a P53 mutation. So I would like to see this study repeated in a biomarker-directed patient population, those patients with an intact P53 gene or with normal P53 expression, where you suspect that there's a wild-type P53 gene that is present. And so I think to do that right, I think it's going to require not just looking at the protein expression, but also gene sequencing.
Now, I've heard there's an ovarian concept. You got any thoughts about that, given the P53 mechanism action that we seem to be seeing here?
Yes, I think it's worthwhile to do these studies with early stopping rules so that you just don't assume things. But I would recommend early stopping rules for assessment of the efficacy of the agent in patients who have P53 mutations versus those that have an intact P53 gene. We now recognize it's just not histologic subtype. It's a lot to do with molecular classification.
That's right. So I, too, always like to read these cost-effectiveness studies, and I do have a certain amount of cognitive dissonance as I contemplate them. When you look at the $100,000 cutoff for whether a treatment is considered cost-effective or not, an amount of money that's 2 to 3 times the median income of a Dallas County family. So should we be leaving Bev out as we look to try to move forward in a cost-effective way?
I don't think, based on the data that we have, we can do that. Would I love to see us be able to minimize the number of drugs that we utilize? Because I think a minimization strategy would also mitigate some of the side effects, not just the cost. But I'm hoping the answer here is going to be biomarkers as well. So one of the things that I've been doing with my collaborators at Duke, Dr. Andrew Nixon, is working on a blood-based biomarker to direct therapy with Bev. And we actually have the GOG 240 samples. So he's running those. We got a grant, R21, to support this study. And I hope I can give you an answer to that next year.
Oh,
but until
fantastic.
And then if we find something of interest there, then maybe I can reach out to the investigators for the keynote study in cervical cancer and ask if they're willing to share samples if they do indeed have samples. Because I think it would be wonderful to be able to identify a serum or a plasma-based biomarker to direct bevacizumab therapy.
So, well, let's think about now. What are you doing clinically? We have a number of patients. They've been getting carbotaxol, cystaxol, with or without Bev, and now we have the new 826 data. How are you incorporating that? Are you adding Pembro to your patients who are already on treatment, or you're just reserving that for your new starts?
So I have added pembrolizumab for patients who are already on treatment. That's not hard to do, once you show them the data. That has been my recommendation in all the patients so far. The new starts, I'll be talking to them about all 4 drugs. I think it's really hard to leave Bev out unless you have a clinical indication to do so. Now, some patients are going to have fistula, a newly formed fistula, or have some sort of risk factor such as tumor involvement with bowel, or maybe other related issues like really bad hypertension that's fully controlled, that I wouldn't put them on Bev for that indication. But right now I'm basing that purely on clinical indicators, not with regard to cost. I'm going to throw that question back at you. What are you doing?
Well, very similar thing. If a patient's doing fine on platinum and taxane alone, then we don't disturb it too much. But particularly if we've got somebody that has had an incomplete response, or you think it might be getting ready to progress, then it's certainly very tempting to add the pembro to that combination. So I want to thank Dr. Secord for her very excellent discussion and analysis, and I hope our audience has found this a interesting adjunct to their virtual or in-person attendance at the 2022 annual meeting. And I'd like to thank you very much for joining us today, and we look forward to hearing from you again. Thank you.
Thank you so much for having me.
Thank you very much, Dr. Miller and Dr. Secord, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, 2022 global conference coverage, and update on the clinical development across gynecologic malignancies, and to download a highlights slide set including the various studies associated with this discussion, please click on the link in the show notes. As always, thanks for listening.